Thank you very much, Vinayak Bhai, for kind introduction, and thank you very much, RSSDI Baroda Organizing Committee and Pratap Jethwani sir for giving me the chance to talk on such a wonderful topic. And it is really this topic, and specifically the molecule, that I have used extensively, and I have very great experience. So I can share our Indian data on this. So if you see the data of NCD Risk Factor Collaboration 2024, and it is not about IDF Atlas, this is very much different data from what IDF Atlas says. So according to this NCD Risk Factor Collaboration 2024 data, India is on top, and almost 21 crore people are suffering from diabetes. China is on second number with 14 crore population who is suffering from diabetes. So total population living with diabetes are around 82 crore, and among them 21 crore is from India according to NCD risk factor. So 30% of our Indian population are untreated, so more than 50% than China. So our 30% of the patients are untreated. This is what data, NCD collaboration data is saying. And scenario of overall metabolism in diabetes, if you see, whether it is insulin secretory defect, it may be hyperinsulinemia, that is insulin resistance, or gluconeogenesis. These three are the basic metabolic defect in any diabetic patients we find. So if we see very old, our med school slide, here if we see in mitochondria what is happening, then there are three major functions are taken care by mitochondria, that is reactive oxygen species production, apoptosis, and ATP generation by mitochondria. So in type 2 diabetes, in relation to mitochondria, if you see, whenever there is mitochondrial dysfunction, it is reactive oxygen species overproduction, lipid accumulation, and ETC leakage, and ultimately, if you see, it causes cellular injury, and antioxidant capacity is reduced with reduction in insulin secretion, and also mitophagy and apoptosis. But at cardiac level, if you see, mitochondrial biogenesis is reduced, so ATP production is reduced, and ultimately it causes cardiac dysfunction. So all dysfunction except cardiac dysfunction, if you see at blood sugar, what changes it makes? At pancreatic level, it reduces beta cell mass. It also reduces insulin production, and also it stimulates secretion coupling. And this is how insulin secretion is reduced, as well as insulin resistance is also increased. And there is occurrence of diabetes or hyperglycemia. So main effects of oral antidiabetics, these are the common oral antidiabetics where there is no role of mitochondrial action or dysfunction. So if you see biguanides or thiazolidinediones, that is pioglitazone, it works at adipose tissue and skeletal muscle level, and it increases peripheral glucose uptake. So glucose uptake is increased, or insulin resistance is reduced. Sulfonylurea, meglitinides, that is repaglinide, we mostly use in India, and exogenous insulin. This all increases insulin secretion, and at pancreatic level it works. SGLT2 is only the drug which reduces glucose reabsorption at kidney level. If you see biguanides and thiazolidinediones, again, they also work at liver level, and they reduce glucose introduction. So hepatic gluconeogenesis, which is actually reduced. Alpha glucosidase inhibitors, we all know that it has insulin independent action, and it reduces glucose absorption at intestinal level. So, do you think there is really need of newer drug or newer mechanism? Definitely, insulin independent action, the drug which has lesser chance of hypoglycemia, this all drugs are welcome. Why GLP-1, SGLT2 inhibitors are so much welcome now? Because they do not cause, apparently they do not cause hypoglycemia. We have used SGLT2 and GLP-1 receptor agonist, even DPP-4 inhibitors in pre-diabetic stage, or we are using it and they apparently do not cause hypoglycemia. So the similar kind of molecule is IMEGLIMIN. Even we can compare it to metformin at some extent. So the need is for drug that address mitochondrial dysfunction, a major root cause of diabetes. It protects beta cell mass and insulin secretion is increased as well as insulin resistance is improved. So it reduces gluconeogenesis in response to glucose at muscular level, as well as hepatic gluconeogenesis is also reduced. So what is this drug? This is IMEGLIMIN. It is the first group of oral tetrahydrotriazine compound. So we are very much hopeful. This is only the first molecule and there are many molecules in this tetrahydrotriazine group. This kind of molecule are coming and we are very much hopeful that it works at mitochondrial level. So it attacks very much pathophysiology of diabetes and this is also welcomed. So if you see IMEGLIMIN, it is approved for type 2 diabetes in Japan in 2021 and in India it was approved in 2022 by DCGI. So differentiated mechanism, if you see, it improves beta cell function and insulin secretion. So it improves beta cell function and it improves insulin secretion as well as it improves insulin sensitivity at the level of muscles and it reduces hepatic gluconeogenesis. So almost 3 different mechanisms where it works. Numerous preclinical and clinical studies are available for IMEGLIMIN. 3 times studies which were done in Japan. There are few studies which are done in India as well and I, Dr. Sanjeev Phatak sir and many of us are part of these studies and this drug has shown promising results. So this drug was mainly introduced by Poxel and Sumitomo Nippon Pharma in Japan earlier. Now we'll go to the mechanism of action. So at the level of mitochondria, it increases NAMPT and increases NAD and ultimately we don't need to go too much into deep, but it increases calcium mobilization in pancreas at the mitochondrial level. So by increasing calcium mobilization, it partially inhibits complex 1, competitive complex 1, it reduces reactive oxygen species formation, it restores complex 3 function, it prevents MPTP opening and increase ATP generation. So ultimately it reduces inflammation as well as it improves insulin secretion. So it improves beta cell function and beta cell protection as well. So it has glucose dependence, insulin secretion increasing. It prevents beta cell death, so it prevents apoptosis of beta cell and it increases function of beta cell mass as well. At liver level, it reduces excessive gluconeogenesis and decreases steatosis. At muscular level, it increases glucose signaling and stimulates glucose uptake as well. So mitochondrial energies, if you see in IMEGLIMIN at muscular level, at liver level and at pancreatic level, it improves glucose utilization, it reduces gluconeogenesis, it improves glucose utilization at liver level. At pancreatic level, it improves glucose secretion and reduces beta cell apoptosis. So IMEGLIMIN provides a novel approach to treatment of type 2 diabetes due to its unique dual mode of action and having both insulinotropic and insulin sensitizing property. Almost any of the available molecule right now in our older molecules, whether it is DPP4, SGLT2 or sulfonylureas, they don't have this dual mode of action. So molecular mechanism by which imeglimin improves glucose homeostasis, it is improving insulin sensitivity, reducing gluconeogenesis. Again, this slide is saying the same thing. If you want to take the picture, please. So it improves insulin sensitivity, gluconeogenesis is reduced, at mitochondrial function is also improved, and oxidative stress is reduced. So effect of imeglimin on insulin secretion and sensitivity, if you see here on the left side, effect of imeglimin on insulin secretion in response to glucose, that is insulinogenic index. They check insulinogenic index, and in comparison to placebo, you may see that insulin production is improved. At stump-wall index, that is insulin sensitivity index, in comparison to placebo, insulin sensitivity is also improved by very good number. So efficacy and safety of imeglimin in Japanese patients with type 2 diabetes, where 24 weeks randomized double-blind placebo-controlled trial was done, and this trial showed, in this baseline HbA1c was between 7 to 10%, where it showed HbA1c reduction of around 1%. Here you can see 1% of HbA1c reduction with imeglimin dose of 500 to 1500 milligram. You can see at 1000 milligram it showed around 0.9% reduction, but at 1500 milligram it almost reduced 1% of HbA1c. But if you really see in our Indian patient, I would rather directly jump to our Indi study. These were times 1, times 2 and times 3 studies which were done in Japanese population, and it showed promising result, and it reduced HbA1c by around 0.8%. There was one R paper, the first author was Dr. Shambhu Samajdar, and we also showed the similar kind of results. While major trials involve Japanese patient, it would be worthy to see our Indian patient data, and for that IndiTimes study which was done, Sanjeev Phatak sir was part of this study, and this was the first large scale study on imeglimin was done, which included around 8,300 patients, where 1000 milligram of imeglimin was used, and there were around 191 sites, and baseline HbA1c was between 7 to 9 for 3 months they used. So this IndiTimes study, where imeglimin in combination with 2 or more anti-diabetic drugs, there were 16% of patients. Imeglimin monotherapy patients were almost 24% with 2000 patients. Imeglimin dual therapy, where 5,000 patients were included, with 60% of the patients were with imeglimin or any other drugs were included. So primary endpoint was to see efficacy of and safety of imeglimin, and secondary endpoint was to assess concomitant anti-diabetic medication prescribed along with imeglimin. And here were the baseline glucose parameters, and HbA1c baseline was 8, fasting plasma glucose was 163, and postprandial blood glucose was 237. So what it showed, this study showed after 3 months, HbA1c reduction was around 1.1%, with fasting plasma glucose reduction of 30 milligram per deciliter, and postprandial blood glucose reduction by 62 milligram per deciliter. So 45% of the patients achieved HbA1c goal of less than 7% at the end of the study. So mean HbA1c reduction in the patient who had HbA1c between 7 to 8, it was around 0.8%, but the patients who had higher HbA1c between 8 to 9%, they showed HbA1c reduction of 1.4%. So this IndiTimes study showed that as a imeglimin monotherapy, it reduces HbA1c by 1.1%. So it reduces HbA1c of almost 1% at every level, whether it is dual therapy or 2 or more drugs with imeglimin. Now HbA1c IndiTimes study with fasting plasma glucose reduction as monotherapy, dual therapy or 2 or more drugs. If you see fasting plasma glucose or postprandial blood glucose level, it showed significant HbA1c reduction in comparison to baseline. So almost 30 milligram per deciliter and 60 milligram per deciliter of postprandial blood glucose. Change in mean HbA1c, whether it is combined with sulfonylurea, bigonides, DPP4, SGLT2 or even insulin, it showed HbA1c reduction of around 1%. With insulin, it was around 0.8%. In comparison of mean changes in HbA1c ranges across overall study population and IMEGLIMIN therapy, overall study population that if HbA1c was 7 to 8, I'll take 2 to 3 minutes more. HbA1c was between 7 to 8, it reduces HbA1c by 8%, but as I said, if HbA1c was on higher side, more reduction was seen, as in all other molecules also we have seen the similar kind of result. If IMEGLIMIN was used as monotherapy, then even the higher reduction with higher HbA1c, it was around 1.5% reduction. In dual therapy, it is also shown 1.4, and IMEGLIMIN plus 2 or more drugs, then even it showed 1.3% of HbA1c reduction. So mean change in fasting plasma glucose, whether you use at 100 to 150 milligram per deciliter, 150 to 200 milligram per deciliter or more than 200 milligram per deciliter, fasting plasma glucose was reduced around 96 milligram per deciliter if fasting plasma glucose was more than 200. And mean change in postprandial blood glucose was around 119 milligram per deciliter reduction if postprandial blood glucose was more than 250. It also shows safety of liver and kidney. It showed nothing significant change. So adverse events, if you see, common adverse events of IMEGLIMIN includes mild to moderate GI disturbances such as abdominal pain, nausea and vomiting. This drug is very well tolerated. It is almost like metformin, but I would say that it has a little better tolerability than metformin. So I have already summarized this IndiTimes study before. So take home message that type 2 diabetes is widespread disease affecting more than 380 million people worldwide. Currently, there are 2 challenges in type 2 diabetes management where insulin resistance and beta cell dysfunction is there. Beta cell dysfunction result from inadequate glucose sensing to stimulate insulin secretion. Therefore, elevated glucose concentration prevail. So, insulin resistance is characterized by diminished response to insulin stimulation, resulting in failure of target tissues to adequate dispose of blood glucose, and mitochondrial dysfunction also lead to type 2 diabetes. And for that we have this molecule IMEGLIMIN, which targets at mitochondrial level, and it improves insulin secretion as well as it improves insulin sensitivity. With this I'll conclude my talk. If you have any question, I would like to address this. Thank you.
Thank you, sir.